Now let's talk generational welfare. HealthCare Ghana has called on government and other stakeholders to fix challenges being faced by the National Health Insurance Scheme, and particularly in the area of its finances. We already have in the studio the Executive Director of HealthCare Ghana, Ebenezer Ajete Sosi, in the studio. And thanks for joining me, sir.
Thank you for the opportunity.
It's interesting what you're coming up with. We know that the National Health Insurance Scheme has run into a lot more financial difficulties lately, especially with its service providers. And so your call is just in line with that, or because you've catalogued a number of difficulties that are being experienced by the publics that you work with?
Yeah, the call is just one of the many issues at stake. First, because we're working with a category of people we have described as largely poor, and so they have some exemption under the National Health Insurance Scheme. And then secondly, about the fact that even though they have exemption, the type of services they are receiving is not what we would call appropriate and relevant to that age group. In other words, until we take on board the issue of geriatric medicine in this country, then of course we are not providing specialized services for other people. We have specially trained medical staff for children, and there's a branch of medicine called geriatrics, which Ghana is ignoring. So this is what we're saying. The National Health Insurance, even though not providing the appropriate in quote services, is also going down, and we think it is good for Ghana for us to salvage it.
Okay, and well, you brought out this very statement on just to commemorate World Health Day, and in the statement you catalog a number of things, and we'll speak to the subject of how you want geriatric medicine also mainstreamed into the curriculum of health training institutions, etc. But on the subject of the National Health Insurance Scheme, how do you think the current status quo is, for which we would need an improvement?
One is about the fact that we have a national aging policy, which defines another person as somebody who's 60 years and above. And then we have an exemption from age 70. Also in a country where the average life expectancy for both men and women is around 63 years. And we think the gap is too much. We also have Senate paying for state pensioners. So they don't pay from age 60. But the fact remains that they are not the only group of pensioners we have in this country. So there is some element of discrimination there, even though it is Senate which is paying. So these are the issues added to the fact that people are growing poorer as they grow older. We don't have any appreciable pension payments in this country. The minimum pension is still below 300 Ghana cedis, and that is a worry. So it is a fact that even pensioners, that is those who are not state pensioners, wouldn't be able to take adequate care of their health in terms of buying drugs as being threatened now by service providers under the National Health Insurance. And we believe that the situation is dire enough. We should not pretend it is not happening. Service providers are threatening, and the fact is that they are carrying out their threats irrespective of the directives issued by the Ministry of Health or the Ghana Health Service. Directives don't solve these problems. Let's give them the money, which is also another issue altogether. If you look at the National Health Insurance Act, one of the sources of income to the National Health Insurance is investment income. So if we can release these monies, which is tax collected on behalf of the National Health Insurance, that's the 2.5%, to the National Health Insurance Authority on time, some investments will be made, and these monies can travel far in terms of taking care of older people. Of course, government also has a social responsibility to fill in the gap if it is not adequate. The other bit of it is now the way we run it. There are a lot of people who have been exempted under the National Health Insurance wrongly. What we call an inclusion. There's a very high level of inclusion and exclusion errors. And that is because we gave some political twist to this scheme at the beginning. I've traveled around and I've encountered scheme managers in the early days who are boasting of that dishing out exemptions. To me, it is not good enough in terms of sustaining the scheme. And as Ghanaians, I think we need to sit up and look at it. The other bit of it is the premium we pay. Is it still realistic for us to pay such a premium to get good health care? We should take away the politics. There was a time we were talking about one-time premium. We should face realities. The other bit of it, which may not also sound very palatable, is that we should leave pension alone and let those who are working pay premium for the national health insurance, because this country is aging. So if you keep on touching pension funds, then of course you are making me vulnerable to grow poorer. Those working should be able to pay their premium, and the money left to the pension fund managers to invest so that people will get something appreciable at old age. We've merged these two things, and they are not going to help us in a country which is experiencing aging very, very fast. I'm saying this because we don't have the time that the developed world had to solve these problems. It is already on us, and we need to do something about it.
And now, for a section of the population which will need a lot more geriatrics as far as the care is concerned for them, and also that very section likely to have the need for palliative care because of that category of age group in which they are. How do you think this could be factored in the meantime before these amendments are made, or perhaps all these considerations are taken by the various authorities, so that we can have the needed care for the aged, so to speak?
To me, the main time is now, starting the mainstreaming. I'm telling you, we have a lot of Ghanaians who have already been trained in geriatric care, in geriatric medicine. But for the fact that the system of healthcare we have
doesn't incorporate them.
So they are all outside. We have a lot of them.
You're one of them.
I'm not. I'm not a medical person. This is purely a medical issue. We have a lot of doctors. And I don't know whether you remember sometimes when you say that Ghana hasn't got a geriatric doctor, the ministry comes out and say there is one geriatric doctor. I repeat, that geriatric doctor is not practicing geriatrics. I mean, let's face it, the person has been trained. But where in this country do we have a health center we can say older people can go for specialized health care? We don't have it. So the fact that we've trained one person, and that was a choice made by that one person. It was not a government policy to go and train that person. We should not claim it. We should stop claiming that person and rather put in the necessary structures to open up the medical healthcare system to this type of healthcare. You know, funnily, in August 2013, WHO supported Ghana to develop a scale-up plan on health and aging. And it is there. It takes on board all these things. Recently, we have another a partner NGO, Akrowa Aged Foundation. They've brought in a college in Holland who are also proposing to start training. But the issue is that this is an NGO. We want these things to be part of the system so that people who are going to be trained will know where they fit. That is it. How can you go and train for something you don't know what to do with after you finish training? That is the issue. I believe strongly that there are a lot of medical doctors who would want to get into geriatric medicine. But you go train and come, and what will you do?
But the point is that if you look at what the more developed economies or advanced countries do, they have sectional facilities for which all these treatments are undertaken, just like you have also cited. But in many respects also, they tend to invest a lot more because it is a social welfare service that needs to be offered, as they have recognized that there's the need for that very care. How do we tend to perhaps do a lot more influence for persuasive purposes, so that policymakers also could be having a buy-in into some of these ideas we're talking about?
To me, we've done enough persuasion. It is an issue of priority. We've done enough persuasion. And I personally would not also accept the argument that we don't have the resources. No country had never had enough resources to do something. It's a matter of priority. And to begin with, I mean, we can start in a very small way. So to me, any social investment is an investment. We are growing older. even the policymakers will grow old. And if they see it from that point, I think we could get there. The other bit of it is not a preventive aspect of it. You know, we need to take preventive medicine very serious. Why should we wait for people to grow old and have all sorts of complications? Then we start dealing with it. We can reduce the cost by getting into preventive medicine. That will help us a lot. This year, World Health Day was on food security and food safety. And look at the environment and the way we cook food and we sell food everywhere. And these are some of the preventive things. We shouldn't wait for cholera, then we go around pouring people's soup and cook food away for 1 week, and then the cholera is over, then we sit down until another cholera day. Cholera is not an anniversary. You know, so this is it. Let's look at the preventive aspect of the issue. Food security, nutrition, you know, all these help people.
As HealthPage Ghana and with the various public institutions that you tend to collaborate with, have you come across a concrete data that gives you some level of aggregation of the number of older people and the segments in which they fall into? That's also tends to do the segregation or the categorization.
In the health sector, no. At the national level, no. At the community level, you have, of course, when you go to hospital, you complete form, you know, they know your age. But as the data goes up, the age gets lost. So you realize that most of the times our report on health is about the diseases. And that is one reason why we are also finding it difficult to take on board some of these issues of older people, especially non-communicable diseases. Because the data is just not available nationally. The data turns into health biased data without taking on board the age. So I think we will find it very difficult saying that this year, this is the main disease that older people reported at health centers. And it's one of the problems. It is one of the problems, taking on board health data. You know, the National Health Insurance, if you look at the Act, Section 30, Subsection 1 and Subsection 3 gives the National Health Insurance Authority the mandate to review the disease and drugs coverage every 6 months. Are we doing it? And the Minister of Health is mandated to approve this. And I think we can start from there. If every 6 months we can take on board one disease that affects older people, I believe strongly, gradually we'll get there. We are not talking about all of a sudden everything turning geriatrics. No, looking at our capacity. But let's start from somewhere, and let's make it a policy that every 6 months we are taking on board a specific disease that affects older people. And we are particularly interested in the ENTs. You know, we have a lot of older people without sight. And if you don't have sight, of course, your participation in the enrollment process is so limited, restricted. If you cannot hear properly, it's limited. If you have problem with your nose and your sight, your taste is adversely affected. And so your nutrition will be affected. So there are complications. These are the geriatric issues we're talking about. Somebody without sight, somebody without hearing, somebody with a problem with the nose will have problems with taste. You taste food and you cannot feel the taste. And that is the beginning of malnutrition. These are the geriatrics. Not that our medical staff cannot take care of it, but the combination of this, for it to give you the indication that this older person who is not eating well might have problem with the ears, might have problem with the eyes, or maybe even having some problems with the nose. All these are the small things we're talking about. We are never saying that our medical staff are not well trained. We are just talking about a specialized area of medicine called geriatrics. And that we can say for a fact, we are not training our doctors in that, and our nurses in that area.
Now, let's talk about the practical examples. What do the older folks or the older generation go through when they want to access health in the typical health facilities around?
Of course, the number one self-report we normally hear is they tell you old age. They can't say Bole. Immediately you go there, you start complaining. I mean, you are sometimes told that, sorry, this is old age, get this rope, those kind of things. That tells you the gap. Old age is not one of the diseases, in medicine. Of course, because of old age, because of wear and tear, weakness of the body immune system, you may frequently have health challenges, but that cannot be called old age. Not all older people have that challenge. And not all older people are using walking sticks. Not all older people wake up and they have joint pains. So definitely there is no disease called old age. And that is one of the capacity problems we have in this country. We've been seeing and we've been hearing that all the time. And they feel embarrassed, as if it is a crime to be old. And this is the number one self-report we've been getting from our older people.
Well, we have on the line Salom Adonu. He's a communications manager for the National Health Insurance Authority. And a very good morning to you, Salom, and thanks for joining us. And we seem to have lost him. We'll try and get him back on the line, and then we'll try and speak to him. Have you been having some dialogue with the National Health Insurance Authority, and how far have you been successful with the dialogue?
We have had dialogue with the Ministry of Health and the Ghana Health Service as a supervising agency, and all the issues we've raised have been raised. Last 2 years, we had a dialogue with the Ghana Health Service, and as I speak now, we book an appointment. A delegation of older people will be seeing the director to look at how far the ministry and the Ghana Health Service or the government has gone in implementing some of the promises that were made to us. Our advocacy strategy is that we are keeping track of every promise you make to us in this direction, and we'll come back and follow up. So this year we're not going with anything new. We're just going to listen to how far we've gone to, because these issues we started raising it about 3 years ago, and we are not going to stop raising it until we see some positive steps, because we will definitely get there, all of us.
Well, we have Salom Adonu, the communications manager for the National Health Insurance Authority, back on the line. And thanks for joining us, Salom. And as far as getting a lot more health attention or care for the older generation, what is there for the services you provide under the National Health Insurance Scheme for the older generation, so to speak? Hello, Salom. Hello, Salom. Well, we seem to be having some difficulty. And so as you do the dialogue with the oversight or supervisory agencies, we have the Ghana Health Service as well as the Ministry of Health, you're hoping that these could be resolved. But for the authority themselves, that is the managers of the scheme, could they do a lot more than usual?
Yeah, that is a plan to...
Ultimately, you want it to trickle down as far as that is concerned.
Yes, we'll be going down.
Now, as far as cost components for the National Health Insurance Scheme is concerned, we know the premiums that are being paid, and you have cited, are inadequate. So, where is the funding going to come from for additional care that will be needed? Because the bracket we're talking about need special care, not necessarily the everyday care that you give a normal generation, so to speak.
Yeah, the funding is there. I'm telling you, the funding is there. That's why we've raised the issue of tackling corruption in the National Health Insurance. Within this country, we've heard reports of names of people who attended government hospitals being used to also make claims in private hospitals. That is corruption. I've just mentioned people who are not qualified for exemption, being given exemption. That is corruption. So to me, the money is there. And I've already said, there's no country which has so much before doing anything. It's a matter of priority. The money is there. Let us look at the premium. Let us reduce the corruption. Let government release the funding meant for the National Health Insurance on time to be invested, and things will gradually improve. Of course, we also have to check the abuse in the system. We have gone around, and the fact is that some of the beneficiaries are also abusing the National Health Insurance. We need to put in place systems to check it. People cannot be going to hospitals anyhow. Of course, we're talking about health, but we have encountered situations where people are just abusing the National Health Insurance. I'm talking about the beneficiaries, and that needs to be checked. You know, we need to see this as a national agenda, as a national gift, and let us all work towards making it sustainable and effective. You don't know when you wake up tomorrow and you have health challenges and you don't have the means to get it tackled. So it is in our own interest to work hard to make the national health insurance sustainable. Let us take politics out of it. And I believe, I hope that come next year, we wouldn't hear politicians going around talking about national health insurance as part of their political decision, unless they are talking about how to improve it. And not about registering people free and underage, even people who are not qualified, and then mobilizing people, paying for them. And then what happens? It is 1 year. So after they voted for you, and you've gone, and you've won the elections, and the cards expire, will you come back and renew it for them? These are the things we need to stop and come out with sustainable suggestions and policies and programs to sustain the scheme.
Now, we're talking about categorization. We know that, well, when people are working, they also need to invest. And you've talked about the informal sector, perhaps those who have not worked with any formal setting. And so we need to also be cared for. The normal social welfare system is supposed to be caring for such people. But how do you conscientize perhaps the current generation that they also need to plan for tomorrow, especially when in a normal human life cycle, your health needs will change. The rate at which you go to hospital will be a lot more when you get older than when you're younger, etc.
Yeah, we are an NGO. We're doing our best. The capacity is not there for a nationwide type of this thing. The issue about social security is not only about Help Ghana. And I don't remember reading anywhere of a social security law which is barring people in the informal sector from joining. It has to do with we as a nation not putting in much effort to enroll those in the informal sector. We have been talking about getting cocoa farmers under the National Health Insurance as far back as 1998 after a research. Of course, we were happy to hear last year Cocoa Board now talking about it. But the farmers, know that they needed it. And they started talking. We organized national engagement dissemination programs to draw attention to the fact that we need to enroll them. Look at it. They sold their cocoa to the nation Ghana. And we pay them, go sell, come back, and make bonus pay to cocoa farmers a political issue. Instead of we even using that bonus to give them social security, can't we pay that bonus into any of the social security schemes? Of course, the major one is SNIT. So that because the bonus is a percentage of how much you were able to sell. So can that be a measure of payment of social security to farmers instead of waiting for political platforms and talk about during our turn we pay cocoa farmers 5% of the world market? I mean, Ghana should grow beyond this type of politics. We need to make our politicians be more interested in national development than their own interests in terms of winning power.
In persuading and trying to do the lobbying for the various interest groups, the state interest groups, so to speak, so that they take up some of these initiatives and inculcate them into policy, where are the benchmarks? Which countries have done it better that you feel, whether they are in Africa or outside Africa and the rest of the world, that we also need to be learning from?
In Africa, we can talk about South Africa, where we even have a universal pension for older people. We can learn from Africa. Let's take South Africa. Fortunately, it is not something being considered. As I speak now, Friday there is going to be a validation workshop in Koforidua to look at the outline of a national social protection policy. In the course of doing the draft of the outline, this issue of universal social pension came on board. And we believe that it will not get lost in the outline so that we develop it. The fact remains that in every society, there are people who need assistance. And look at it, the Constitution, if you look at Article 37, 6b, it tells us that the government should give social assistance to the vulnerable in society, including older people. So supporting older people and other vulnerable groups cannot be said to be so costly that it cannot be done. It is a constitutional right. The only difference is that unlike the capitation grant, it didn't give any time frame to get these things implemented. But there is a constitutional reason why these things are being raised. The Constitution mandates the state to provide social assistance. National health insurance is a social assistance. It's a social protection scheme. So taking on board older people and other poor or vulnerable people onto national health insurance is not too much for Mother Ghana. The Constitution provides for it. And these are the issues. So I believe that Friday, by the end of the day, we will be able to validate that aspect of the National Social Protection Policy outline. And I repeat, there's a constitutional reason why it should be done. As for whether we have money or not, I don't believe it. We have the money. If you reprioritize and we reduce the corruption in the system, we're taking Mother Ghana for granted. Too much. We do things in the...
So for you, it's a matter of priority?
It's a matter of priority.
Okay. What is the current statistics as you have it now that you tend to do your projections with? Per the population and the growth at which we're going to have a lot more people falling into that very bracket, so to speak. And what usually is the categorization?
Yeah, we now have about 7% of our population being older people, and that is about 2 million. That is about 2 million.
If we're talking older people from what age, 60?
60 years. But you know, the momentum in the system is that why we are having these numbers. There is another momentum somewhere, and that is the fall in the fertility rate. You're having the ratio of older people to children increasing. So what is going to happen statistically?
I'm lost. Well, older people to children, meaning what?
For example, say in 1984, when we had a census, assume you have 10 children in Ghana will be
by an older person, or by, let's
say, it's equal to one older person in Ghana. In 2000, the same 10 children are now to 3 older people in Ghana. That is the momentum. So the issue is that we are having a cohort of young people.
So you're talking about the ratio per older person. You have less children,
but more
per an older person.
Yes, per older person. And so the issue that we're going
because of lowering fertility rates.
And so we are going
couples are having less children.
Yes, and it has to do with we also even very positively pushing the girl child into education. These things hit one another, and so if the policy is not comprehensive, you will end up solving one and creating another problem. That is the challenge we're having in this country, as to push more girls into school, which is very, very positive. The issue is that you are making them, all things being equal, unavailable for early marriage, all things being equal. It may delay.
Your statement is very discriminatory.
I'm saying it is positive.
Okay. You're saying that increasing girl child education is positive.
Very positive. But what I'm saying is that it has got its implications.
Okay, so you're saying that's the implication. I guess then you have to do your wedding the other, you could be misinterpreted in many respects.
I agree. We're doing one positive thing, which has got an implication.
So you're saying that whilst we are doing the positivity, we also need to tackle the likely repercussion.
Yes, and that is development.
So that's what we're not doing.
That is what we're
saying girl child, and we're saying family planning, etc. But then we're not looking at what the repercussion could be decades later.
Look at another one about pension. Now, if you look at the old state scheme, the pensioner has up to 72 years on paper to die. I'm just saying it raw. I'm not wishing anybody.
That is if you live up to that.
Yeah,
point.
72 years.
That's where that's a limitation against
the limitation
for you to receive still.
Yes, but it is the pension is until you die. And so look at statistics
but
now.
it's not like that for those on Cap 30 either.
It's what?
It's not like that for those, let's say, who are in the military or the security services. They receive till they die.
And Senate, they also receive till they die. And so when we are revising our pension scheme.
What's the new one saying? I haven't read about it.
Yeah, the new one.
Or you also haven't done some.
The new one, we now have the 3-tier.
Sure.
And recently, just last December.
Is there any limitation to it?
No, there is. You are still being paid till you die.
Okay.
You are still being paid till you die. But we are a little bit concerned about the fact that we reduce the voluntary retirement age. You know, the voluntary retirement age to 50, which is quite also not distant.
So it means that if people are 50, they can decide to retire. And you are saying they get to add to the backlog of older generation.
And the fact is that
who would need specialized care, for which we don't have the care and the facilities to care for them.
That is it.
All right.
These are what I call implications. There are good reasons why we do one thing. But after finishing with that, we just don't have the time to look at how it impacts on others, for which reason why we need to make some adjustments. Sometimes the impact is not that negative. For example, somebody may retire voluntarily for a good reason, to go and do something which will generate better income, isn't it? But the fact is that are people really prepared, retooled, so that when they retire voluntarily, they will be able to sustain their life, continue the contribution, so that at old age, they will not fall into the
We have a
poverty.
larger section of our population who undertake informal work. And of course, the current pension law now has gravitated to look at those very needs of the older people. Of course, we haven't been able to conscientize them enough to take up some of those facilities, so to speak. But you look at market women who don't pay formal pension, now they have the access to be able. But for those who will not be paying, how are NGOs like yours or another civil society or let's say community groups making sure you tend to rope in such sections of the population just for the betterment of their future, so to speak?
Yeah, we have been educating people to get on board.
I know you do.
Yeah.
Is it being done holistically?
We're doing our best. You know, we are an NGO, but look at another funny thing. We've made a 3-tier voluntary. The 3-tier, where people can easily fit from the informal sector, is voluntary. And those in the formal sector, it is compulsory, mandatory to be in the first, and then the third, and then the 2nd-tier. But the 3rd-tier, where we can also make it mandatory, excuse me to say, for people to understand that contributing to pension is almost a mandatory issue in Ghana. We made it voluntary.
Because you can't force people.
You can't force people.
You can't force people to be contributing, and especially when that can be used just as some sort of a net investment, so to speak.
You can't force people to contribute, but at the end of the day, you have a social responsibility to those people. We know that.
So you are saying we should make it. We should have been able
I think we should
make it more compelling.
More compelling for people
for let's say a taxi driver.
Just to contribute to pension.
Be mandated.
Yes, and I think
by compulsion. How?
Well, whatever means we can do it. I think for the fact that the state.
So ideally, we go to the taxi rank or their parking area and say, have you contributed? Have you contributed? You're not contributing, and so you're liable to be summoned or searched.
No, I'm not looking at that. What I'm looking at, making it more attractive to the extent that it becomes a compulsory thing without they even knowing that it is compulsory for them. You cannot force people. But the issue is that the state has a responsibility towards those people. So if you allow them to get into that trap, you will be called upon to intervene.
Okay.
And we know for sure that pension fund in some countries is a huge source of investment for national development. Are we looking at the pension funds that way? That the more people who contribute towards it, the more money is made available to invest and make this country move forward. This is what I'm calling comprehensive development. Yes, it is pension, but that is also money that can be used to develop this nation so that it will be sustained. And when somebody is in need, at least the person wouldn't talk like he or she has been neglected by the state when he has not done any contribution. In some countries, people contribute over 50% of their salaries into schemes so that when they grow older, they will be taken care of. Why are we shying away?
We'll see how that goes, and especially the aspect about those in the informal sector worries me a lot, and especially when you have a lot more interactions with those in the informal sector, you get to know that, well, 20, 30 years down the line, when these people perhaps are not agile enough to work, what happens to their health and their livelihoods? And well, we'll be having in the studio Beneza Ajete. So say the pronunciation is what?
Saucy.
Saucy. Okay.
The indigenous is Saucy.
Saucy. And he's the executive director of HealthCare Ghana, and they are advocating that a lot more older people need to be roped into the National Health Insurance Scheme and need to be cared for another scheme. And we're taking a break. When we come back, we'll be having in the studio our guest for AM Talking. So do stay on. We'll have a lot more for you.